Welcome back, everyone. And we're going to continue on. We just had a really great discussion of sort of the origins and the formation and the implementation of PEPFAR. And we're going to continue now with a deeper dive into PEPFAR. And we have two wonderful panelists. And I'm going to introduce them briefly because we're getting a bit of a late start. But we're so pleased to have Dr. Rebecca Bunnell, who's the Principal Deputy U.S. Global AIDS Coordinator for PEPFAR, where she helps oversee the implementation of the $6 billion annual budget of PEPFAR across 50 countries. And Dr. Bunnell has lived and worked around the globe in Uganda, Kenya, and Honduras, with the Peace Corps, USAID, CDC, Médecins Sans Frontières, and the UK MRC. And Dr. Bunnell earned a Doctor of Science degree from Harvard School of Public Health. Welcome, Dr. Bunnell. And then Dr. George Ngomela is the Associate Director of Programs at the US CDC in Tanzania, where he provides strategic leadership, technical oversight on HIV and TB programming to support the One CDC collaborative. Dr. Ngomela is one of CDC's designated agency leads for PEPFAR interagency work, and he helps guide the high-level strategic direction for the PEPFAR program in Tanzania. Dr. Ngomela is a medical doctor and an epidemiologist with 2 decades of experience in clinical medicine and global health, and has studied and worked at the Wellcome Trust Sanger Institute, Harvard University, London School of Tropical Medicine and Hygiene, and Muhimbili University College of Health Sciences of the University of Dar es Salaam. So a warm welcome to Dr. Bunnell and Dr. Ngomela, and I'll turn things over to you. Please do note questions as we go along, and we'll make an attempt to get to those questions when we get to the end. Welcome.
Thank you so much, Patrick, and good afternoon to everybody on the line. Really appreciate this opportunity to share a bit more about PEPFAR. It was absolutely wonderful to hear Mark Dybel's overview on the history, which is very inspiring. I'm sorry, I'm getting a joint audio to start speaking. Are you hearing me okay?
Yes.
Okay, all right. I'll ignore that. I know we talked a little bit in the Q&A about books that people are writing. And I would just say that as we kind of venture into this section, I think we're still writing the additional chapters of this book. So the story is not over. There's a lot more that we're doing and a lot of the journey ahead. So what I'm going to focus on is really talking a little bit about the current status, where we are right now, and draw on some of the parallels between the work we're doing globally and the work that many of you are engaged in through your affiliation with PACHA domestically. And I think one overarching commonality is that we both have an ambitious goal. In the PEPFAR world, and I think you're also part of this, we have a goal of reaching 2030, and a point in time when HIV is no longer a public health threat in the way that we're experiencing it now. And I know EHE is also an inspirational goal or mandate that we have domestically. So we can get into a conversation about whether those are the right goals, but we share that common mission. Next slide. In addition, I think both Jen and Patrick talked about the importance of our bidirectional learning. And as we were preparing for this discussion, we thought about how, although the domestic context and the global context are different, we have a lot of common and consistent challenges. And those range from things like a constrained fiscal environment in which we can operate, a challenge of explaining that HIV is still a priority in at a time when there are many other public health and other pressing priorities for our communities, for our nations. Linked to that is the overlay of other pandemics, such as Mpox most recently, but others as well that are concurrent. There is a constant and very welcome body of work that brings both new science and new innovation, but this requires us to leverage it and keep up to date with it. And I'll talk about that a little bit. We share common challenges in the important work around equity and reaching and ensuring equitable access to services for key populations, priority populations. I think men, both MSM and men in generalized epidemics is a key priority population for the work we're doing globally. And linked to that are common challenges around interruptions in treatment. So those are just a few. I'll touch upon part of where we are, where we've come from, and how those challenges play out in the global arena, and let you all reflect on the parallels domestically. Next slide, please. So as Dr. Deibel described, we have made tremendous progress in our fight to end HIV as a public health threat. Here you can see just sub-Saharan Africa. PEPFAR works in 55 countries, but we have a heavy concentration in Africa. And just over the last 14 years or so, you can see the progress in terms of the percent of people at the population level who are living with HIV and on antiretroviral treatment. And you can see the countries in red, it was below 75%. And the progress we've made in recent years, we are striving to get to dark green for all countries. Next, please. We also have been able to document tremendous results in terms of cumulative lives saved, over 25 million, 5.5 million babies born HIV free. I won't go through all of these. These are on the web, but you can see various components of our service delivery work we've done in partnership with countries and some of the extraordinary results. Next, please. Dr. Deibel spoke about countries heading towards extinction, and that was particularly evident in the number of orphans and the prevalence of HIV infection in children and pediatric deaths. In red on these charts, you can see what the situation was. Mark described this quite vividly, but pre-PEPFAR. And then in blue, you can see the impact of PEPFAR going forward. And I am going to switch to another camera. I'm sorry about that. Okay, let's keep going. Next slide, please. While these gains and successes have been tremendous, they are also fragile. And we've done some work to look at what would happen if we were to end PEPFAR today. And if we were to end PEPFAR today, we would rapidly see, over 1 million more HIV infections in children by 2030, big spikes in pediatric deaths and in orphanhood, as just some examples of the consequences of abrupt ending. Next, please. I mentioned that one of our shared vulnerabilities, and this is important for our shared context, is the fiscal environment. And here you can see just PEPFAR funding and what it looks like when you adjust for inflation. And adjusting for inflation, we've really seen a 30% decline in funding from a peak of about 8.2 billion to 6.4 billion over time. And you can see the proportion going to Global Fund. So this has, in and of itself, really pressured us to move even further towards that sustainability. And we'll be talking about that later this afternoon. Next, please. our work is really grounded in a 5-year strategy that Ambassador Nkengasong released just in the beginning of his tenure. And that strategy has 5 main pillars. Again, we'll talk about a number of these. Health equity is number 1. Sustaining the response is number 2. Systems work, partnerships, and science are all part of our central strategy. Next, please. I think Mark also alluded to some of the unique characteristics of PEPFAR, and I wanted to just highlight a few of them. One that has been referenced quite a lot is our interagency approach that has really brought in a diversified pool of talent and reach. We've also had very close hand-in-hand partnerships with the governments in our partner countries, driven by a country operational plan process and defined minimum program recommendations and requirements. Extensive use of data. You'll see a lot more about that. And then a lot of work on that science pillar and ensuring we integrate and translate science as quickly as possible. Next, please. The other unique characteristic, I think, of PEPFAR that's really one of its core strengths is the spirit of partnership, where we really have a 3-pronged partnership between government, civil society, people living with HIV, and then other partners, PEPFAR being one, but also UNAIDS, Global Fund, and other global partners. And these partnerships really form a coordinated approach that will be essential as we move forward. Next, please. I wanted to highlight how some of those partnerships kind of play out in practical terms. One of the things that PEPFAR does continuously is put out guidance that really draws out all the technical guidelines from WHO. These are well-established, scientifically grounded in strong bodies of evidence, and these are used to form our technical considerations and COP guidance, and we're actually in the process of doing that right now for our next round of country plans. Next, please. Our steer and our overall epidemiological metric of success follows, the global framework of 95, 95, 95. I know that's not always used domestically in the same way we do. We talk about the 95s all the time, but we're really striving to ensure that 95% of people living with HIV know their status. Of those, 95% are on antiretroviral treatment, and of those, 95% are virally suppressed. If we achieve this in a country, or a country achieves this, and that would translate into about 86% viral load suppression at the population level, which by some estimates will contain further spread of HIV, or at least bring it down to a level that can be reasonably managed in public health terms. Next, please. So our approach right now, our current approach, as we kind of look towards those longer term goals, I think was alluded to by Jen, is really to focus on the gains that have been made and to accelerate our progress toward those 95, 95, 95 targets. So let me share a couple highlights around this. Next slide, please. When we think about sustaining the gains, we need to think about not only the successes, but the fragility. Here again are some of the successes that were highlighted earlier. But in the absence of a cure or a vaccine, our results, our successes, our country partners' successes are incredibly fragile. You saw that with children in the earlier slides. Next, please. So as we are sort of simultaneously working to sustain gains and accelerate progress, there are some fundamental challenges that we are confronting. On the side of really sustaining the gains, we are, through PEPFAR, currently supporting over 20 million people on treatment and supporting them in a way that ensures that they achieve and maintain viral suppression, and that treatment interruptions are prevented, which of course will decrease the risk of death, of HIV transmission, and of drug resistance, is incredibly important. Our second major challenge area is to close persistent gaps and inequities that remain in our work, and those include gaps and inequities for men, for youth, for key populations, including LGBTQI+, and for children. Next slide, please. So in terms of
I think you got muted accidentally.
I think you hit mute.
Sorry about that. I was just saying that in terms of treatment interruptions, these are data from all of our countries, and an analysis to show where are we seeing treatment interruptions. These are data, just recent data from Q2 of FY24. And as you can see, the biggest proportion of treatment interruptions are occurring amongst men, shown in blue, in the ages of 20 to 44. So that age group is one that we realize that our programs are not fully meeting their needs, given the high numbers of the high proportions of treatment interruptions. Next, please. We also have seen gaps in key groups, and those include that youth have much lower likelihood, 10 to 20% lower likelihood of knowing their HIV status relative to all adults. They include that children have a 40% lower rate of viral load suppression at the population level relative to adults.
We lost you again.
Yep.
I'm so sorry. Key populations, we have seen that incidence is 3 to 11 times higher relative to all adults. And likely, as I mentioned, and finally, as I mentioned earlier, men have 3 times the risk of transmitting HIV in comparison to women. This is in generalized epidemics. Next, please. Next slide, please. I wanted to do a little bit of a deeper dive, just to mention something that we're working on a lot and that we're very concerned about, which are countries where there's a hostile environment, in some cases hostile laws, such as Uganda, where we have the Anti-Homosexuality Act in place, and how concerned we are around our ability to provide services for men who have sex with men and transgender and other populations in that context. So I just wanted to share some of the things we're doing to address that. I think in Uganda, there's some good examples of ways that community organizations and partners that we are working with on the ground have developed innovative strategies to ensure safety and access for people in a person-centered way that tries to circumvent the really hostile environment. And this is something that we are aggressively supporting and looking to expand capabilities and capacities of civil society, organizations that are working to support communities, LGBTQI communities in particular. We can talk a little bit more about that. It was something we announced a new strategy action plan just recently at Munich around this. But I just wanted to flag this again, an area we could talk a lot about, but an area of great concern for our program. Next, please. Finally, I want to turn to data. And it's been alluded to the fact that PEPFAR has really changed the way global health programs use data to set and achieve targets and to really help level set progress. And this is just a list of some of the data streams that we support centrally through PEPFAR. And I won't go through all of these, but we're actually working right now to kind of streamline these as we move into a more sustainable model for the future. But these have been super important to inform our progress. And they also include national level surveys as well as routine programmatic data. And to really give us a better view on what this looks like, I'm going to turn to my colleague George in Tanzania to really give us a deeper dive of how they have successfully used data in Tanzania to drive programming. And want to give a shout out to George because he's been such an important leader in this space. George, passing it on to you.
Thank you. Can you hear me?
Yes.
Okay, great. Perfect. Yeah, good evening from Tanzania, and my name is George Mgomela. I am the Associate Director of Programs at CDC Tanzania, and I'll start the presentation today by providing you a bit of background on HIV in Tanzania. Tanzania is considered to be a high-burden country with a generalized HIV epidemic. Per the most recent UNAIDS estimates, there are approximately 1.7 million people living with HIV, and prevalence is higher among women than men. Tanzania has made tremendous progress in responding to the HIV epidemic over the past few decades, having tremendously curbed new HIV infection and AIDS-related death. However, as you will see later in this presentation, work remains to be done to reach the United Nations Joint Committee for AIDS 95 targets and end HIV as public health threats by 2030. Next slide. Next slide. It's important to note that PEPFAR has been supporting the government of Tanzania. It's important to note that PEPFAR has been supporting the government of Tanzania to respond to the HIV epidemic since 2004. Over the past 2 decades, PEPFAR has invested over $6.6 billion in all aspects of HIV response in Tanzania. PEPFAR Tanzania's current budget for financial year 24 is about $432.7 million, and will decline to $380 million in financial year 25. A large part of PEPFAR Tanzania's success over the last 2 decades can be attributed to investments in the collection and the effective use of high-quality HIV data to inform the response. Next slide. PEPFAR Tanzania utilizes a wide range of data to inform programming, including routine programmatic data, modeling estimates, and results from special data collection activities like surveys and other studies. While all type of data sources ultimately help to fill in the gap of the picture when it comes to assessing the ultimate impact of the programming on the HIV epidemic in Tanzania, periodic population-based HIV surveys provide indispensable high-quality data. Today's presentation will focus on how PEPFAR Tanzania has effectively used survey data to monitor and maximize the impact of our programming and inform policies. Next slide. In recent years, PEPFAR Tanzania has supported the implementation of 2 Tanzania HIV Impact Survey, commonly known as a THIS in Tanzania. One was in 2016-2017, and a more recent one was conducted in 2022-2023. The THIS were a high-quality representative survey designated to provide robust and gold standard estimates of the key HIV measures, notably HIV prevalence, incidence, and the status of the progress toward the UNAIDS 95-95-95 targets in Tanzania. Like all PEPFAR countries is striving to achieve our journey to HIV epidemic control. In the rest of this presentation, we will take you through how results from the first HIS in 2016-2017 were effectively used to maximize the impact of our efforts before highlighting how the results from the recent HIS in 2022-2023 show the impact of these efforts, but also, importantly, helping us to chart the course of our current and the future efforts. Next slide. As we just mentioned before we look on how results of the most recent HIS are guiding our current efforts, it's important to look back 7 years ago when the results of the HIS 2016-2017 highlighted the gaps in our efforts to reach HIV epidemic control and served as a catalyst for crucial geographic and programmatic shift. In response to Tanzania's substantial gap in the first 95, we showed that only 61% of the people living with HIV aged 15 years and above in Tanzania were aware of the HIV status. PEPFAR Tanzania supported a widespread and a rapid scale-up of safe and ethical index testing, which you'll also hear a little bit more about it in the next slide. Tanzania was also able to roll out multi-month dispensing to all eligible clients, executed 2 major ARV drug regimen transition, and started a nationwide PrEP program. And importantly, we were able to shift to a model of a person-centered care. Although relevant results are not shown here, the THIS 2016-2017 was also crucial for refocusing Tanzania efforts in the geographic areas with the largest remaining treatment gap. Next slide. When you think about this major shift in the wake of the results from THIS 2016-2017, perhaps none was more impactful than the subsequent rapid national scale-up of safe and ethical index testing, which has proven to be the most effective strategy for reaching undiagnosed people living with HIV. Index testing is a testing modality which seeks to test contacts of people living with HIV, including their sexual partners and their biological children. In the year following the release of THIS results, PEPFAR Tanzania worked to rapidly and widely scale up index testing in a safe and ethical manner, which did not put people living with HIV at additional risk. This scale up led to substantial increase in the number of new HIV positive cases being identified and subsequently linked to ART. Even as identification started to drop off as an overall gap have closed, index testing continued to account for almost over 50% of all the new positive HIV cases in Tanzania. While other efforts such as changing the Parliamentary Act to lower the age of consent for HIV testing to 15 years also had an impact to index testing scale-up, was a game changer for the HIV response in Tanzania. The rapidity with which we were able to achieve would not have been possible without the momentum created by THIS 2016-2017. Next slide. Fast forwarding to most recent times, the impact of all the aforementioned shifts were evident in the results from THIS 2022-2023. As shown here, THIS 2022-2023 revealed that Tanzania has made tremendous gain across the 95 cascades since the THIS 2016-2017. Most importantly, the proportion of PLHIV aged 15 years and above who knew their status improved dramatically from 61% in 2016-2017 to 83% in 2022-2023. And this translates to approximately 400,000 people able to know their HIV status during in between the two time periods. We also saw an important progress in the second and the third 95s. Next slide. To put it in more simple terms, the THIS 2022-2023 show that nearly 8 out of 10 people living with HIV aged 15 years and above in Tanzania were virally suppressed, a huge testament to the success of efforts in Tanzania. However, much like the THIS 2016-2017, Tanzania has worked to use the results for the THIS 2022-2023 to identify remaining gaps and target our programming to fill them. As you saw in the previous slide, case finding still remains our largest gap, and renewed efforts are required to reach more than 15% of the PLHIV that did not know their status at the time of the THIS 2022-2023. Next slide. THIS 2022-2023 also highlighted the gap among subpopulations. As we've heard earlier, HIV burden is uneven and unequal across different populations and regions. As seen in the top left, overall, HIV incidence estimates for men and women aged 15 years and above declined since 2016-2017. However, the incidence among young women aged 15 to 24 years increased. Similarly, in the bottom left, you can see that the proportion of women living with HIV aged 15 to 24 years and men living with HIV aged 25 to 44 years who were virally suppressed were substantially lower than among their older counterparts. Subsequently, the THIS 2022-2023 results have been the driving force behind Tanzania's recent efforts to intensify existing interventions, innovate new strategies to reach key subpopulations, and to employ a regional rather than one-size-fits-all approach. The next slide will showcase how we are using THIS 2022-2023 results to reach the young people. Next slide. The THIS 2022-2023 and the program data highlighted the gap in youth programming and a need for new innovative interventions. As a result, PEPFAR Tanzania held a consultation forum with the youth representative to understand their knowledge and experience with the HIV services. Hearing directly from the youth on their concerns, needs, informed a ranked list of proposed interventions to guide our program implementation. New activities, including testing at the youth, informed hangout and social media campaigns to address the knowledge gap and to drive demand for testing, treatment, and prevention services. PEPFAR Tanzania continues to work to close the remaining gap across all regions and to reach specific subpopulation using the data to inform targeted and evidence-based interventions. Next slide. As I close today's presentation, I would like to highlight two key takeaways. Number one, national representative surveys such as Tanzania HIV Impact are feasible and impactful investment to guide programmatic decision-making and inform policy changes. As highlighted, the government of Tanzania and PEPFAR Tanzania have used these surveys results and program data to improve the progress to reach the epidemic control. New and innovative interventions led by data are needed to fill PLHIV to find PLHIV who are not reached with the current service delivery models. Data-driven programming tailored to subpopulations and regions are essential to close the gap and reach our 95 goals.
Great.
So
George,
thank you all for listening. And I'd like to acknowledge all my colleagues in Tanzania and all people living with HIV, with whom we've been working very closely. Thank you.
Great.
George, thank you. Thank you so much. We have just a couple of slides. We're going to go super fast, Patrick, so we have time for discussion. But George, I think you really covered the example of how much data can help us. And the Tanzania example is excellent. Next slide, please. It's been very important for us to focus on and close equity gaps, particularly in priority populations. Next, you've also, next slide, please, shown us about youth. And I want to turn to the next slide and just very quickly, next slide, share with you a little bit about PrEP. We have done a tremendous scale up on PrEP. This is showing oral PrEP. We've had a doubling in 2 years. We have over close to 2 million people on PrEP, primarily MSM and adolescent girls and young women. Next, please. And we're keeping our eyes very much on the whole pipeline of new PrEP products that we see coming up. We're keeping our eyes on there because we want to be well prepared for a rapid scale up as products become available. Next, please. And one example is around long-acting CAB-LA, which we were able to be supporters of the second country globally in the world to introduce CAB-LA. We now have CAB-LA started in 4 countries. We are aiming to reach 12 countries before the end of this calendar year. And we're looking forward to future expansion on CAB-LA. Next, please. We are also looking very carefully, I think Mark Dybel mentioned this, but looking at modeling and seeing the impact of long-acting agents. In this case, these are models looking at CAB-LA, but looking at the impacts on HIV prevalence, incidence, mortality, which are all very important for us as we balance how we can spend our limited resources and advise countries at the country level. Next, please. So one of the things that is very important for us, and I'm sure is an issue domestically as well, is just making sure that we don't do an either or situation where we shift all our attention to PrEP and not close the persistent gaps in treatment and viral load suppression for people living with HIV. And we have seen in a number of settings the importance of viral suppression in men to reduce incidence in women and young girls. And lastly, just wanted to, last slide, please, just show how challenging it is for us right now as we look at lenacapavir. We are working very hard to be ready to go as soon as there is FDA approval, so that we have service delivery models ready and we have the resources, the skill sets on the ground ready, but at the same time balancing how much money we put towards that biomedical prevention intervention vis-a-vis continuing our efforts to scale up treatment as prevention. And I will stop there, and I think you can take down the slides. Patrick, back to you. If there are any questions, we're happy to address them.
Wonderful. Thank you both so much. We do have time for 2 expedited questions. So if people want to put up hands, I'll call, and be great to use this last few minutes. Jen.
Oh, mine will be quick, and maybe we can get into it later, but I'm just so struck every time I see the PrEP scale up slide. And the contrast with the US domestic situation where, you know, it's been documented over so much time, the need to increase the number of people at risk on PrEP, and just the numbers are not really going up. If you could encapsulate what were like what were the ingredients that allowed you to so quickly, relatively speaking, scale up? And again, maybe that's a big question, so we could get into it later, but I think that would be very helpful for PACHA members to understand.
Patrick, did you want to take
do you
it?
want me to answer now, or we wait for the second question?
Yeah.
Maybe take the last, since we don't have a lot of time, take Carol's. And then
Yeah.
Shall I go? Yeah.
Yeah.
I just want to acknowledge how you closed out with the interconnectedness between undetectable and then the decrease in new incidents. And in particular, you know, you used the example of sustained undetectable in men and how that led to a decrease in incidence in women. And I think that interconnectedness between U equals U and prevention needs to be better stressed in all of our work, right? And that slide and that little case study, if you will, epi case study, really brought that home for me. And I just want to really acknowledge that.
Thank you, Carol, for that. And I'm sorry I rushed through it because we did actually cite U equals U at the bottom. I know we'll be talking about that further in this session, but it's absolutely important and absolutely central to the progress we've seen. And it's something that we're also promoting, U equals U, and look forward to doing more of that across countries. George, I want to let you talk about the Tanzania experience. Let me just give just a quick high-level comment to Jen's question about how were we able to scale up PrEP so quickly. I mean, a couple things. One, we had platforms like the DREAMS program where we already had, you know, programs working with high-risk adolescent girls and young women who have very high incidence in many countries. We already had platforms established, so we were able to leverage those. And there was huge demand and interest in PrEP. And likewise, we were able to use some of our community partnerships for reaching key populations of men who have sex with men, other high-risk groups that we were, you know, they were very interested in it right from the start. And I think it's that preparation in advance, the work we're doing right now, for example, already starting to plan around lenacapavir, even though there's no FDA approval, even though we don't even have Purpose 2 results out yet, we know it's coming. So we are literally meeting on a daily basis at the country level. This will be folded into our next couple of years planning so that as soon as we have product available, all of this is going to be dependent on price in our case. But as soon as there's product available, we have the policy barriers addressed. We've thought about the behavioral, the communications, the service delivery issues, and we're kind of ready to move. But George, you were on the ground and you've done a lot of work. I know there's been some policy barriers in Tanzania around PrEP, but do you want to share anything from the Tanzania perspective on PrEP scale up?
Yeah, thank you. Yeah, so there've been police barriers at the highest level in Tanzania, is similar to many other low and middle income countries. There are challenges in terms of stigmatized and criminalized groups, such as people injecting drugs, men who are having sex with men. And what we've been able to do, regardless of the police barrier at the highest level, we've been able to work with the different local organization, local leadership, local government leadership, and to really be able to inform them that this is important to close the tap of the new infections. And we've been able to find creativity around the model which I talked in my second slide, the personal-centered model, to ensure that if someone comes to the clinic and they say they're at high risk of HIV, then we'll offer them a screening tool understand their level of risk, they'll get counseling, and then they'll be initiated treatment as part of their risk factors, regardless of the media barriers. But at the same time, we're able to talk to the government of Tanzania at the central level, and we're able to start systematically as a demonstration project, a small scale in one place. And then when they saw there's no challenges, then we continue in another place. And at the moment, we're having it nationwide in a specific places, but we're still working very hard with GHSB and other colleagues on the ground to ensure that we roll it out countrywide. But also I want to touch a little bit, if I can get a minute or so, collaboration. We've really collaborated with PEPFAR headquarters, but also have collaborated with our individual agencies, USAID, DOD, and also CDC to like really get technical assistance. The government of Tanzania, particularly at the regional level, and health facilities were very helpful. And we also work with the civil societies to ensure they continue making the noise, they continue pushing the government. And we were able to make a site level monitoring at every site. We're able to identify what will be the potential level, a potential number of people require these services. And we continue addressing that challenge at site level. And eventually, when you aggregate all these numbers from the site level to a regional event to the national level, is a substantial number of people who have been prevented from acquiring HIV disease. Thank you.
Thank you. And we have one last short question, speed round. So Mackenzie, if you want to ask your question, we'll have a minute or two to respond.
Wonderful, yes, and thank you, Patrick. Rebecca and George, thank you both for being here so much. Really appreciate it. My question is kind of foundational, and maybe it's really simple, but I've Googled around a bit and I couldn't find an answer to it. I'm just curious about how much the government through PEPFAR is paying for the medications on like a per prescription basis relative to perhaps the best like apples to apples comparison would be like how much a CMS or an ADAP or Medicare here on the domestic front is paying for those medications.
George, you can come in from a Tanzania perspective, but and Jen Cates probably could answer this question as well, but I believe at this point in time, through generic purchasing negotiations, et cetera, we are paying $42 a year per patient annual for antiretroviral treatment. Jen, correct me if that's wrong.
It's very, very low at this point. I was going to say around 100, but I know it's gone down, and that's for the ARVs themselves.
Yeah, that doesn't include the cost of service delivery infrastructure.
But in the US,
it was much higher initially, and we've worked very hard with many partners to bring that down.
Yeah, maybe I can also say very quickly that before PEPFAR in Tanzania, there are only 1,000 patients who were on ARVs in the whole country, and these are predominantly wealthy people, and it was very costly. People had to sell properties, etc. But now we are having approximately 1.5 million people, 1.6 million people on this life-saving, and the cost has really gone down. But also, basing on the evidence, we've worked, some of these surveys and research we've been doing. We have put all the medication regimens into 3 layers. We have the first line, second line, and third line. So majority of people will be in the first line. So when you negotiate, as Becky said, it becomes cheaper. And then very few people will fail the first line for one reason or the other, maybe drug resistance, etc. They'll go into second line medication. And then very, very few in the whole country will eventually maybe go to the third line medication because of HIV drug resistance. So having the guidelines of these very specific regimens also, which is across many countries, helps PEPFAR and the Global Fund to procure a large amount of medication, and majority of people will be in a specific type of medication, which, because of the economy of the scale, lowers down the costs. Thank you.
All right. Well, please give your virtual or other type of appreciation for Drs. Bunnell and Gomela. This was really a fantastic session. We are going to take a break until 3:35, so you get about 15 minutes to stretch. We'll start back right on time, and we'll see you all shortly. Thank you again so much to our presenters.
Produced by the U.S. Department of Health and Human Services.